Welcome to today's ADA National Network COVID-19 special session. I'm Louis Krause from the Pacific ADA Center, your moderator for this series. This webinar is brought to you by the Pacific ADA Center on behalf of the ADA National Network. The ADA National Network is made up of 10 regional centers that are federally funded to provide training, technical assistance, and other information as needed on the Americans with Disabilities Act. You can reach your regional ADA center by dialing 1-800-949-4232. Real-time captioning is provided for this webinar. The caption screen can be accessed by choosing the CC icon in the meeting control toolbar at the bottom of your screen. To toggle that meeting control toolbar on permanently, you can press the Alt key and press it again if requested. We also have ASL interpreters at the top of the screen in video. As always in our sessions, only the speakers will have audio. If you do not have sound capabilities on your computer or prefer to listen by phone, you can dial the following numbers: 1-669-900-9128 or 1-646-558-8656 and use the webinar ID 848-5731-3035. I want to remind everybody that the webinar is being recorded and will be able to be accessed on the adapresentations.org website and the archives section next week. The Pacific ADA Center hosts two webinar series. Today's special session is a combination of both series as the topic relates to both areas. The healthcare and the ADA webinar series is intended to share issues and promising practices in healthcare accessibility for people with disabilities. The series topics cover physical accessibility, effective communication, and reasonable modification of policy issues under the Americans with Disabilities Act of 1990, the ADA. These monthly webinars occur on the fourth Thursday of the month at 2:30 Eastern Time, 1:30 Central, 12:30 Mountain, and 11:30 a.m. Pacific Time. The Emergency Management and Preparedness webinar series shares issues and promising practices in emergency management, inclusive of people with disabilities and others with access and functional needs. The series topics cover emergency preparedness and disaster response, recovery, and mitigation, as well as accessibility and reasonable accommodation issues under the Rehabilitation Act of 1973, the ADA, and other relevant laws. These monthly webinars occur on the second Thursday of the month at 2:30 Eastern, 1:30 Central, 12:30 Mountain, and 11:30 a.m. Pacific Time. Upcoming sessions are available at adapresentations.org under the Schedule tab, and follow to the appropriate section for either healthcare or emergency management. By being here, you are on the list to receive notices for future webinars for those series, and those notices go out 2 weeks before the next webinar and open that webinar to registration. You can follow along on the webinar platform with the slides. If you are not using the webinar platform, you can download a copy of today's PowerPoint presentation at the Emergency Preparedness Schedule page of adapresentations.org. At the conclusion of today's presentation, there will be an opportunity for everyone to ask questions. You may submit your questions using the chat area within the webinar platform, and the speakers and I will address them at the end of the session, so feel free to submit them as they come to your mind during the presentation. To submit your questions, you type in the chat area text box, or if you are using keystrokes, press Alt and the key H and enter that text in the chat area. If you are listening by phone and not logged into the webinar, you may ask your questions by emailing them to adaTech@adapacific.org. That's ADATECH@adapacific.org. If you experience any technical difficulties during the webinar, you can send a private chat message to the host by typing in your chat window. Again, to type it in that text box, you hit enter, or if you're using keystrokes, use the keystrokes of Alt and a letter H to access the chat box. You can also email us any technical difficulties at adatech@adapacific.org, or you can call us at 510-285-5600. Today's ADA National Network special session is titled, "Has the COVID-19 vaccine effort worked for people with disabilities?" In this presentation, CDC survey data will be reviewed that shows adults with a disability are more likely to report difficulty getting a COVID-19 vaccine compared to adults without a disability. Despite disparities related to COVID-19 vaccine access, adults with a disability are less likely to report vaccine hesitancy compared to adults without a disability. In addition, we will hear real-life cases and situations that emphasize that disparity. Finally, resources will be reviewed that are aimed at improving vaccine access for people with disabilities. Today's speakers are Dr. Blythe Ryerson. She's the Acting Director of the Division of Human Development and Disability in CDC's National Center on Birth Defects and Developmental Disabilities. The division's mission is to lead inclusive programs, surveillance, and research to improve the health and development of children and adults with or at risk for disabilities. During the COVID-19 pandemic, Blythe has stayed committed to continuing to build on the division's foundation of work while exercising agility to improve health equity for people with disabilities during public health emergencies. JJ Rico is the Chief Executive Officer at the Arizona Center for Disability Law, which is the protection and advocacy agency in Arizona, providing free legal services to people with disabilities. JJ has dedicated his 20-year legal career representing people with disabilities, specifically focusing on the employment and access provisions of the Americans with Disabilities Act. So Blythe and JJ, I will now turn it over to you.
Great. All right, can you hear me all right, Louis?
Absolutely.
Great, thank you so much. Good afternoon, everyone. I really appreciate the opportunity to present and join in this discussion. As Louis mentioned, my name is Blythe Ryerson, and my pronouns are she, her, and hers. And since I'm not on camera today, I don't need to give you a physical description, but I do want to thank our ASL interpreters and captioner up front for their services today. Next slide, please. Oh, okay, here we go. Since launching an agency-wide response to the COVID-19 pandemic on January 21st, 2020, CDC has deployed over 9,800 personnel to our Emergency Operations Center, all the while maintaining our day-to-day public health programs. As Louis mentioned, in the Division of Human Development and Disability, our mission is to lead inclusive programs to optimize the health and development of children and adults with or at risk for disabilities. So, as you can imagine, as the only center with exclusive expertise on the health of people with disabilities at CDC, we've been intimately involved in trying to ensure health equity for people with disabilities throughout the pandemic. Our small division has been involved in nearly all aspects of the response, from understanding disease spread and burden to mitigation efforts, including COVID-19 vaccination. Today, I'm going to be focusing on some recent data coming out from two different surveys that both highlight unfortunate disparities in COVID-19 vaccination access by disability status. Next slide. So first, I'm going to briefly review what we know about the burden of COVID-19 in people with disabilities. Next slide. Depending on a variety of factors, including questions asked or the sampling frame of the survey, CDC estimates that the prevalence of self-reported functional limitations in the year 2019 ranged from 9.5% in the National Health Interview Survey to 26.7% nationwide in the Behavioral Risk Factor Surveillance System. People with disabilities are more likely than those without a disability to have chronic health conditions such as coronary heart disease, diabetes, obesity, and hypertension. And of course, they face barriers to accessing healthcare. Next slide. These and other health and social inequities have placed people with disabilities at increased risk for COVID-19 related illness and death. For example, while much attention was given to the heightened risk for residents of traditional nursing home facilities early in the response, many people with disabilities, other people with disabilities required direct support or care, decreasing their ability to maintain safe distances away from potentially infected or unvaccinated individuals. And people with certain cognitive or communication disabilities may have been unable to receive or understand appropriate preventative messages, especially early in the response. Next slide. So this slide shows results from a study that I was not involved in, but it gives some good background. And it's a bar graph showing odds ratios on the y-axis, and on the x-axis are a number of different risk factors for COVID-19 diagnosis. Now, I do want to say up front, unfortunately, as is frequently the case, information about health risks for people with disabilities is often not collected. So this particular study is from a cross-sectional study published earlier this year, and it included over 64 million patients at over 500 healthcare organizations from January 2019 through November 2020. It was one of the first studies to come out documenting disparities in COVID-19 infection and outcomes for certain people with disabilities. And so after adjusting for other risk factors, including age and comorbidities, people with an intellectual disability had a 2.6 higher odds of COVID-19 diagnosis than those without an intellectual disability. And this was the highest odds ratio observed of all the characteristics and underlying medical conditions analyzed. People with neurological disorders had a 1.2 higher odds of COVID-19 diagnosis. Next slide. So this is a similar graph, looks very similar odds ratios on the y-axis and the conditions or characteristics on the x-axis, and it's showing the risk of COVID-19 hospital admissions. And it shows that people with neurological disorders had a 3.4 higher odds of hospitalization than those without, and people with an intellectual disability had a 2.7 higher odds of hospitalization. Next slide. And then this is probably the most stark results from this study. It's again the same type of figure, and it shows risks of mortality due to COVID-19. And it shows that people with an intellectual disability had almost 6 times higher odds of death from COVID-19 than those without an intellectual disability. Only older age was more strongly associated with the risk of death in this analysis. And people with neurological disorders also had an increased odds, though it was similar in magnitude to other risk factors analyzed. Next slide, please. So taking a step back for a moment, we need to acknowledge that people with disabilities are a heterogeneous group, and factors associated with their underlying disability and health, how they perceive and interact in the world, or where they live or work may impact their risk for COVID-19 and severe outcomes. This is a framework I like to use that tries to incorporate both the medical and social models for defining disability. The upper portion is meant to illustrate that different disorders or injuries can occur throughout the lifespan, but that regardless of whether they are considered or associated with a quote underlying medical condition or special healthcare need, these diagnoses or identities can and will impact people differently and may result in limitations within different domains. For example, two different people with an autism spectrum disorder diagnosis, the same underlying condition, may experience very different limitations within different domains, social, communication, learning, or thinking. Whereas a person who is deaf may or may not consider themselves as even having a disability, since many can communicate using American Sign Language, simply considered their native language. Next slide. In any case, there's a dearth of public health data for people specifically with disabilities, and measuring disability status can be quite difficult. The Affordable Care Act includes several provisions aimed at standardizing, collecting, analyzing, and reporting of health disparities for people with disabilities, and explicitly requires that the Secretary of the Department of Health and Human Services establish data collection standards for disability status. The law requires that once established, these data collection standards be used to the extent practical in all national public health surveys. Currently, the HHS standard consists of 6 questions listed on this slide. They focus on the domains of vision, hearing, remembering and thinking, movement or mobility, self-care, and independent living. And we'll come back to this measure of disability when we begin to delve into the data in a moment. Next slide. It's here that I want to mention that collecting any disability data during the COVID-19 pandemic has been very challenging. In some of the earliest days of the emergency response, we learned that the case reports being sent from state and territorial health departments were largely missing disability status. And in fact, less than 7% of them had disability status information filled out at all. And so to reduce the burden on our public health colleagues on the front lines, it was ultimately decided to remove this field altogether from the case report form, since we weren't getting usable data. Similarly, the administrative data systems that typically track vaccination rates, termed the immunization information systems, do not collect disability status. Therefore, we've had to rely on special surveys to track COVID-19 vaccination status for people with disabilities. So today, I'm going to review results from 2 separate surveys: the National Immunization Survey, or NIS, and the Household Pulse Survey. I'll start with the NIS. Next slide, please. All of the immunization survey results that I'll provide today come from a recent Morbidity and Mortality Weekly Report, or MMWR, that was published on October 1st. Next slide. The National Immunization Survey is a group of telephone interview surveys conducted by our colleagues in the National Center for Immunization and Respiratory Diseases here at CDC, and it's meant to monitor coverage of all childhood and adult immunizations. They use random digit dialing of cell phones stratified by locality to sample the non-institutionalized children and or adults, depending on the vaccine they're monitoring. In April of this past year, or this current year rather, an adult COVID module was added to monitor the COVID-19 vaccine specifically. Next slide. When disability status got removed from the COVID-19 case report forms that I mentioned earlier, our division became very engaged in data collection efforts across the agency to try and improve the information coming in specifically about people with disabilities. As we began these discussions with our colleagues across the agency, it became clear very quickly that the HHS 6-question standard was not going to be feasible during an emergency response such as this. And so we had to very quickly, I think we were given, a week or two to convene experts across the agency and other areas of federal government to come up with a single question. We were given one question to come up with. And so we decided to develop and pilot a compressed form of the HHS 6-question set in the immunization survey adult COVID module. So I'll read what that question is. It says, it asks, do you have serious difficulty seeing, hearing, walking, remembering, making decisions, or communicating? Next slide, please. As soon as we had a large enough sample size from the NIS adult COVID module coming in, we began analyzing the data. Responses were weighted to represent the non-institutionalized US population and were calibrated to state-level vaccine administration data, the IIS systems I mentioned earlier. And because older age is associated with more disability and higher vaccination rates, we adjusted our analysis by age. Next slide, please. Overall, 9.4% of respondents reported having a disability, which, if you'll remember, is very similar to the prevalence noted in the 2019 National Health Interview Survey, but substantially lower than our nationwide estimates from the Behavioral Risk Factor Surveillance System. Nonetheless, adults with a disability in this survey were less likely to report receiving at least one dose of the COVID-19 vaccine, yet more likely to report they would get vaccinated. Next slide, please. So here is a graph with age-adjusted prevalence ratios comparing people with disabilities to without on the y-axis and different answers to questions on the x-axis that I'll go over in a moment. But among unvaccinated adults, those with a disability were more likely than those without to report they were very or moderately concerned about getting COVID-19. They also were more likely to think the vaccine is very or somewhat important for protection, reported many or almost all friends and family members as vaccinated, and had a healthcare provider recommend the vaccine. Next slide, please. I don't show it here, but overall, adults with a disability were more likely than those without to report that it was somewhat or very difficult to get a vaccine. And this observation was more pronounced among the unvaccinated, which is what's shown in this figure. So what I'm showing is that among unvaccinated adults, those with a disability were more likely than those without to report having the following difficulties associated with getting the vaccine. About 2 times more reported having trouble getting an appointment online or getting to a vaccination site. And vaccination sites were also reported to not being open at very convenient times. And they also didn't know where to get the vaccine as frequently as those without a disability. Next slide, please. And because you'll see, we observed similar patterns in the data I'm about to show from the Household Pulse survey. I'm going to wait to talk about the implications of the data until I show you results from both surveys. Next slide, please. There's not a publication yet from the Household Pulse survey data, but the data are available on CDC's COVID data tracker online. And in fact, we have a tab for people with disabilities and vaccination rates under health equity data on the COVID tracker. And there you can view these data. They're actually updated every 2 weeks. And so what I'm about to show you is probably outdated, but you can get the most recent data in the COVID tracker. Next slide, please. The Household Pulse survey is administered by the US Census Bureau and was started as a way to measure how the pandemic was socially and economically impacting US households. Adults are sampled from the census's master address file, and adults are contacted by phone or email and invited to complete a 20-minute online questionnaire. By the third wave of this survey in April this year, we were successful at getting disability questions added. Next slide, please. Although we were still limited in the number of questions we were allowed to include, we were able to add a few more than the National Immunization Survey. We actually got 4 of the 6 HHS domains added. Specifically, those were seeing, hearing, remembering or concentrating, and the mobility or movement question. Next slide, please. Like the NIS, sampling and appropriate survey weighting is done to attempt to represent a national sample of the non-institutionalized US population. Though it's important to note that the data I'm about to show from the Pulse survey and what's available on the COVID tracker are not age adjusted. We decided to just present crude results. So there could be a little confounding by age, and I'll point out where that's likely in a moment. Next slide, please. Here I'm showing a bar graph of vaccination rates by disability status as reported into September. It's shown overall and by age group. And we observe that people with a disability are less likely to report receiving at least one vaccine, COVID-19 vaccine, as compared to those without a disability. And this holds regardless of age group. Next slide, please. And here you'll see that the pattern holds regardless of disability type. So we're showing, again, bar graphs by disability status for the domains of seeing, hearing, mobility, and cognition. And people with disabilities have lower vaccination rates in all areas. Next slide, please. The Pulse survey also asks about vaccination intent. And here we see that at least when we're looking at the unage adjusted proportions, people with a disability may be a little more hesitant to get the vaccine than those without a disability. But again, these are not adjusted for age, and there's not huge differences between disability status. Next slide, please. Lastly, before we begin the discussion, I do want to point out that these data have some very important limitations. First, self-reported vaccination coverage is consistently higher in these surveys than in the administrative data sources. Specifically, the Pulse survey is about 7.7 percentage points higher than the proportions you would see when looking at the immunization information systems. This could be due to a variety of reasons, including what's called social desirability bias. These surveys also have relatively low response rates, or there could be limitations to how the sampling frames are done that impact generalizability. However, it's important to note that there's still a strong correlation between these various data sources. And so despite the stated limitations, self-reported survey data are still very useful when we're looking at relative differences between groups. And then finally, I want to point out that the question we fielded on the National Immunization Survey is new and unvalidated, and the questions included on the Pulse survey do not capture all the domains required in the HHS standard. So neither measure is complete. They could be very complete assessment of disability status, or we might be masking important observations in certain disability subgroups. Next slide, please. So finally, what are some of the implications from these data? Next slide. First, let's summarize the findings one last time. Compared to adults without a disability, those with a disability had lower COVID-19 vaccination coverage, yet in age-adjusted analyses were less hesitant to get vaccinated and more likely to think the vaccine is important for protection. These observations lead us to believe that there's a real potential for increasing vaccination coverage for this large, diverse group of adults who are also particularly vulnerable to COVID-19. Next slide, please. The not so good news is that adults with disabilities anticipate or experience more barriers to vaccination. Specifically, they report difficulty getting appointments online, not knowing where to get vaccinated, getting to vaccination sites, and reporting that the vaccination sites are not open at convenient times. As such, it's critical that we, as the public health providers, reduce barriers to scheduling and make vaccination sites more accessible. This is a no-brainer for anyone with lived experiences or for those working in the disability and health field, but these national data provide documented evidence of these disparities. Next slide, please. I think one more slide, please. I'm not seeing the slide advance. Louis, are you there?
Yeah.
Do you want me to just keep going?
I'm stuck.
There we go. Great. Shall I continue? Louis? You want me to continue?
Yes.
Okay. All right. Great. So there are some relatively easy, tangible steps we can take to remove at least some of the barriers identified. First, we can translate COVID-19 health and vaccination messages into accessible formats, including American Sign Language, Braille, and easy to read. We can make vaccination registration and scheduling websites more accessible. In fact, a recent exploratory analysis of official state and territorial registration websites found substantial variability and suboptimal compliance with even the most basic accessibility recommendations. Fortunately, there's information widely available for developers to make web content and scheduling systems more accessible. For people who are unable to access electronic information or make appointments online, we can provide call lines and live vaccination scheduling assistance. And of course, for people unable to easily leave their homes, we can provide options for in-home vaccination services or provide access to accessible transportation. Next slide. Our division has made some headway in many of these areas. We've developed a large suite of accessible COVID-19 materials. We've developed dozens of resources for people with intellectual and developmental disabilities, including videos, social stories, interactive materials, and posters. And we've been doing our best at translating CDC COVID-19 messages into Braille and ASL, with over 54 messages now available in Braille and 40 in ASL through a partnership with the Georgia Tech Center for Inclusive Design and Innovation. We've developed and delivered multiple listening sessions and webinars with state and territorial health departments and other partners working in this space to provide strategies for vaccinating people with disabilities more effectively. And we have provided over $100 million to the Administration on Community Living to create a national call center for linking people with disabilities to vaccination services and providing grants to local aging and disability networks in all states and territories to help vaccinate people with disabilities. Next slide, please. So as you can tell, I'm very proud of the work our division, agency, and partners have done over the past 2 years to address some of the health inequities for people with disabilities during the pandemic. However, as the vaccination data I presented points out, there's still much work to do. Next slide. Even with the current efforts, we're still seeing disparities for people with disabilities and the risk for COVID-19 and its severe outcomes. We also continue to see vaccination rates for people with disabilities lagging due to important and frankly avoidable barriers. Fortunately, one positive that has come out of the pandemic is that I do think we're beginning to see a reckoning within public health and more acknowledgement of this being a critical area for health equity work. I'm beginning to see more attention paid to issues around disability status measurement and inclusion in public health preparedness and response work. And I hope this momentum will continue so that disparities for people with disabilities can be better mitigated in the future. Next slide. And so, of course, I need to thank many people across CDC and our partners. These are just a few from my division, from the National Center for Immunization and Respiratory Diseases, and the National Center for Health Statistics. And then, of course, there are countless other people who have lived on and off the CDC emergency response for the past 2 years. So huge thanks to everyone who's worked. And with that, I think I have one last thank you slide. And I'll turn it over, I guess, to Lewis or JJ.
Hi, Blythe. This is Lewis. I will apologize. Thank you very much, first of all, for a wonderful presentation. I apologize about the technical difficulties. We were having trouble being able to speak to you. That's why when you were asking, we weren't there. All right, so we will move now to JJ. And before we do that, one other impact of the technical difficulty: if you sent a chat message earlier in the question earlier in the Blythe's talk, please resend that if you can remember your question, because we ended up losing all of our chat messages. So, all right, JJ, on to you.
All right. Thank you. Good morning, good afternoon to everyone. Appreciate everyone for being here today. And I want to thank Dr. Ryerson for her presentation. I think it's very informative, and also I appreciate the conclusion that much work still needs to be done, more research, health equity for people and the disability community specifically. So thank you so much for the work that you've done in the investment in this issue. I really appreciate Lewis making this an event both for the healthcare ADA group and the emergency preparedness group, because I think both audiences need to have this discussion, be engaged, and also work on solutions. We're still living in a pandemic, and our goals are still to get as many people vaccinated as possible. So as the first slide says, my name is JJ Rico. My pronouns are he, his, and him. I am the CEO for the Arizona Center for Disability Law. We are the designated protection advocacy agency in Arizona. There is an office like ours in every state and territory. So after listening to me, you're like, gosh, I wish there was someone like that in our state. I'm telling you, there is. You can visit our National Disability Rights Network website at ndrn.org and find the state agency or territory agency for you to contact and reach out to and hopefully partner with. So let me jump into my first slide and generally say that I'm going to make a lot of the same suggestions that Dr. Ryerson did as well, in ways to make vaccine sites more accessible. I'll share a little bit about how Arizona has done, but also just generally the Americans with Disabilities Act's requirements for these vaccine sites and for websites. So a lot of this applies, almost all of it applies across state lines. So if you're wondering like, oh, does this apply in my state? It most definitely does. And so the two titles of the ADA that we're going to focus on, or that apply to the situations that we're going to describe, are Title II of the ADA that applies to state and local governments, and Title III of the ADA that applies to places of public accommodation. So if your state is hosting private run vaccine sites, or you have your Walgreens or CVS, that would be Title III. If it's state run sites, like in Arizona, we had big stadium sites at our Cardinals football stadium or at the University of Arizona, that would be Title II of the ADA. And we're also going to be talking about the reasonable modification provisions under the ADA. along with the requirement that auxiliary aids and services be provided. So if you have questions, I think I saw a question in the chat regarding accommodations or modifications in other areas. We could briefly address that as well. I know we're going to leave plenty of time at the end of my presentation for questions and answers. So please fill up the chat, and I'm sure both Dr. Ryerson and myself will be able to address as many as possible. Next slide, please. All right, so the thing I want to emphasize and that we've seen in Arizona is that when we were advertising for vaccines, the information was being delivered through websites, and websites are not always accessible for various reasons. I saw a comment in the chat that not everyone has access to a computer or to the internet. That is very true. That is 100% true. We also have diverse communities that have limited access to strong internet signals to access information. We in Arizona, when the state website first went up, it had no live person or way to request reasonable accommodations. That has been recently updated, so we're very happy about that, but I don't know if that's something that you all have seen in your states. And so I know I tested it myself for me when I was trying to access when I could get vaccinated or where I could get vaccinated, and there was not a live person to answer those phone calls. The person that I talked to actually wasn't able to answer my questions, and I did not have even accommodation needs. And so when we received phone calls from the disability community, it was most definitely a barrier where they wanted to make sure that there was either reasonable accommodations going to be provided or how a particular site was set up so that they could achieve their goal of receiving their vaccine. So I'll give you an example. So as I shared, Arizona rolled out at one of the huge football stadium or big group vaccination sites. You saw the administration come out and celebrate that as a great way to get folks vaccinated. Unfortunately, it wasn't the best way for people with various disabilities, specifically people who did not have the ability to drive in because it was a drive up site. Those who relied on transit transportation did not allow for a drop off and pickup. Those were challenges. And then also at some of these larger sites, if you had to wait in line for long periods of time, oftentimes there were not places to sit or opportunities to keep your place in line so you could still get your vaccine. Just a few challenges in some of those large sites. The additional items that we heard was the large sites did not always provide effective communication, specifically American Sign Language or basic communication cards. And our Arizona Commission for the Deaf and Hard of Hearing did an excellent job of creating some communication cards that sites like this or any sites could use, but that was not always being implemented. We participated in some conversations and it was known about, the communication cards were known, but they were not being used. And so I would say tip one for the day is to make sure that if you do have reasonable accommodations, know what they are and educate those who are answering the phone calls or establishing the website so that they can put those up front and center. So very important that your front facing information, whether that be a website, whether that be a person answering your phone call, know about reasonable accommodations or know if someone's asking for assistance or help, how you can get back to them. So I know not all scenarios can be answered immediately, but the number one issue that we hear, regardless if it's access to vaccine or some other form of an access issue, is that the frontline person or the frontline website says we don't provide that. And so my second tip of the day is to say, if you don't have an answer, rather than say we don't do that, the best tip would be to say, I'm not sure, I will get back to you. And so again, sounds really basic, but I think sometimes those who answer the phones may get a little concerned if I have to give an answer. And as a lawyer, I can tell you when I first started practicing law, I felt I had to give my clients an immediate answer. But I've learned over time is if I don't know the answer, I better go back, research it, and come back with the researched information. So that would apply in this situation as well. One of the other tips I would say is that group scheduling helps people with disabilities who utilize a caregiver. Not all people with disabilities have caregivers, but a group scheduling process benefits that. And I'll just give you an example in Arizona. Our independent living center in Phoenix, Ability 360, hosted a vaccine event. They allowed for group vaccine scheduling. So it really became not only a caregiver and person with disability event, it became a whole family event. And so you had grandparents and parents and children. At that time, I think it was 12 and up, were able to get their vaccines. And it really benefited many people so that they could get vaccines at one time. The other positive of that event that we have not seen at all events is a live person answering the phone to address accommodation requests. That's still, to me, the best way that someone can ensure that they're going to show up at a vaccine site and get the accommodation, is a live person gathering that information and then ensuring that that person will receive the accommodation that they need to get their vaccine. So again, last tip on this page is, again, an appointment process that allows for the ability to request for reasonable accommodation. Now, some of you might be screaming at me and say, JJ, that's so simple. Why do you even put that out there? But I can tell you, just within the last couple of months, we've worked with some vaccine equity organizations that didn't know that was all it was needed, and they've started adding it. And I want to applaud their effort for doing that, because again, it's a simple step, but it means so much for the disability community to see that language on an announcement, regardless if it's vaccine or a training, that they know that they are going to be accommodated and that the site is accessible. So let's move to the next slide and talk about accessible sites. Right. So the site accessibility. So a lot of folks assume that every site that hosts a vaccine event is immediately accessible. We don't want to make that assumption. As the new 5 to 11 vaccine is being rolled out, I've heard in some conversations that they're going to utilize in Arizona a lot of schools. Now, there's an assumption because there's children with disabilities that go to a school that it is immediately accessible. And I have had to share that that does not always mean accessibility. We in Arizona also have a voting grant where many schools are used as voting sites. And so we've done a lot of survey of these schools for voting purposes and have identified that oftentimes schools, school parking lots are not adequate, do not provide adequate accessible parking, especially in the location in where either in this situation where the vaccine is going to be administered. So let's say it's in the gymnasium. So I'll just give you a hypothetical. So if the gymnasium is being used, you want to make sure and ensure your parking is an accessible path from that parking lot to that gymnasium, because oftentimes you'll see the accessible parking maybe at the front of the school, closer to the office. So you want to make sure if there is not designated parking that you create some, because we are advocating to make sure that you can even establish temporary parking. So a lot of sites might say, oh, well, we can't do that. We can't restripe our parking lot. There are temporary ways that you can identify parking. And I would reference the Department of Justice parking requirements so that not only do you have accessible parking spots, but you also have van accessible parking spots, and block off that van accessible aisle. Unfortunately, a lot of people think, oh, there's a small little spot, I'll squeeze in there. That is for van accessibility, to make sure someone can lower their ramp, get in and out of their van. So again, just a tip there. Also, if you are going to provide access to bathrooms or restrooms at your vaccine event, make sure that you do have an accessible bathroom. Again, we all, if that is going to be provided, we all need access to the bathroom. And there are ways to provide accessible bathrooms even in a pop-up site. There are, I don't know, again, the lingo across state lines, but there are porta potties or porta johns that do have accessible features that are accessible. Now, are they fully accessible? They may not be. But again, if you are hosting an event and you do not have a restroom, put that on there, that there was not restroom available. So folks that may need that know that they might not be the location that they want to go to. So we talked about parking, sensory items and sensory options. So that's for various disabilities. So we'll use an example of a person with autism. Sensory items could include, or sensory options could include, a location or space that is not overload. For example, a lot of these first events that were coming out, they were really big events. The one I went to at the University of Arizona had music playing and had fans and people kind of celebrating that, you're getting vaccinated. And that's good, right? That's generally good, but that could be overwhelming or sensory overload for an individual who does not benefit from that celebration. So do you offer a separate room? Can you dim the lights? There are a lot of options to remove some of the sensory items. The other thing you can provide are items that allow for someone to, a squeeze ball, a stress ball, other items like that could also help. It also could be a good way to get information out about how to register for a vaccine. It could have a logo or a website, so there's a dual purpose there as well. Keeping wheelchairs or places to sit on hand, as a result of a phone call or two that we received about individuals not being able to stay in line. Now, the lines I know for vaccine aren't what they used to be, but they are still existent. And I do understand from the 5 to 11 group, there are going to be some more group sites that may, especially in the beginning of this rollout, I do anticipate some longer lines. And obviously you're going to also have families coming to these events. So there will be more people waiting in line. So if there are options to sit or wheelchairs that could be provided so someone could sit if they're not able to stand for long periods of time. In-car vaccinations are another option. Now, I don't know what every state has done, but I've heard about this in many states. Arizona has done this. This benefits a lot of folks. Mine was in-car. I didn't have to get out. Second one, I had opened my door, but other than that, I was able to get my vaccine. And so for some who do have, the ability to either utilize a car, get in a car, this can benefit them as well. So they don't have to get off, go into a site that may be inaccessible or may pose a barrier to getting the vaccine. The last tip on this page is plain language signage. Now, we talk a lot about effective communication, but I think we miss the plain language nature of information. And when I talk about plain language, it is the ability to convey a message in a way that the majority of people can understand. And when I say the majority of people, I would say that the last information I received was that our reading level in our society as a whole is about 6th grade. It might be a little less, it might be a little bit more, but we should learn how to write as clear of information as possible. Now, I know vaccine specific information could be high level, but I'm talking about directions. I'm not going to the side effects issue, but mainly directions, information on how to get to a vaccine site, how to get from the parking lot to the vaccine site. The disability community relies heavily on signage. And so when I've done this presentation for folks in Arizona, sometimes I worry that they think I'm asking them to create permanent, metal signs that, are going to cost thousands of dollars and take months to create. I'm talking about printing out large signs with arrows on them that say right, left, that really just allow someone to navigate from this parking lot we're talking about to the vaccine site, or clear messaging on the door of what the process looks like, with information on a phone number to call, or with information on the website to register. And this also, plain language applies to that website information as well. A lot of words on a small page can overwhelm someone, can also distract from the message. So again, dark background, light font, focusing. Again, this allows access for many different people, not only just in the disability community, but beyond. So a lot of these tips are universal accessible tips, But I would also say that this is not just COVID vaccine related. This also applies to healthcare access issues. So appreciate any thoughts or comments in the chat on anything. And I see some good questions going up there, and we most definitely will get to those. So thank you. Next page, please. Let's talk a little bit about effective communication. Big issue because there's, I believe, a misunderstanding, and maybe not for everyone in our virtual meeting today, but first address American Sign Language. American Sign Language is not English. There are two different languages. And so sometimes people assume, oh, I'll just write notes back and forth. Especially complex information like that, that would not be effective communication. And so I think so some basic exchange about communicating a vaccine appointment, whether or not someone's registered, that could be relayed through the communication card that I explained or that I shared earlier, or through some brief notes. But for that medical appointment where the person is going in and needing to ask questions about the side effects, about the dosages, those type of items, effective communication through another method, specifically American Sign Language interpretation, might be needed. But it's always important to ask, because I always remember one of the first cases that I dealt with years ago when I first started my career, where a court provided American Sign Language interpreter to someone later deafened in life who did not speak American Sign Language. So although well-intentioned, it was an investment in something that did not effectively communicate to my client at that time. That client benefited from CART or transcription services. So it's always important to ask and always important to make sure you're providing effective communication. Next is have lots of tools in your toolbox. I'm giving you ideas, I guess you can call them tools and tips. Have as many available as possible. But make sure you know they're available, or make sure those who are helping you know they're available. When we first saw the vaccine being rolled out, there were a lot of volunteers part of this process, and it was difficult, I'm sure, to make sure that everyone had the same information. But as the vaccines sites have grown smaller, more direct from the CVSs and the Walgreens and the doctor's offices, make sure that people know that you have a toolbox. And then second, that they know what tools are in there. And so related to effective communication, you're going to want to know how to access a sign language interpreter, right? So a lot of folks have been asking me, well, who do we contact? So in Arizona, we contact our Arizona Commission for the Deaf and Hard of Hearing. They're not only a great resource, but they're also in charge of licensing our sign language interpreters in Arizona. So I don't know every state, but it would be a real quick Google to make sure that you have information on who to contact regarding securing a sign language interpreter or a transcriptionist, depending on the need, the effective communication need. All right. You want to provide fact sheets on vaccine ingredients, side effects. I've seen a lot of good one-pagers out there. So you don't have to reinvent the wheel. There seems to be a lot of information, as we heard from Dr. Ryerson, really nice fact sheets, tip sheets, a lot of videos that are being used. I know I'm supposed to work on a video, a TikTok video. So again, try to diversify your messaging, but make sure it's effectively communicated as well. Do not rely on automated captioning, although it's better. It most definitely is not a substitute for real transcription. We talked about communication cards and wearing clear masks, making sure that if you do have someone who has the ability to read lips and benefits from someone wearing a clear mask, still have some of those on site. But reading lips is not a substitute for sign language interpretation or other communication, but it may allow for someone to access some information when they're trying to communicate at a vaccine site or in person. So just have that again, that's part of your toolbox. Next slide, please. So I'm actually good on time here. And so I'm going to say, here are some great resources. There's a checklist on site accessibility broadly, just sites generally. Web accessibility, that's been a big issue as we've done these presentations in Arizona, is where do I find those guidelines? So here's some guidelines. There was a recent Department of Justice settlement against, I believe it was Rite Aid, for having an inaccessible website for vaccine registration. So just be mindful of that. That resolution may have some good guidance in it on what to avoid. And the last is the Office of Civil Rights. In case someone does encounter a barrier, this is a great site and resource on the standards prohibiting disability discrimination. So again, another great resource. Do I have another slide, or I think that is my last slide? My contact information if you have other questions, but also reach out to your disability rights organization in your state. There is so much good information out there. My closing comments would just be, we have a long way to go. I think Dr. Ryerson's presentation really highlighted that people with disabilities want to get vaccinated. They just want to know how, where, and to make sure they're not facing barriers when trying to get vaccinated. So it takes a group effort. For all of you who are out there trying to reach that goal, I appreciate you. I think good partnerships. The one thing I've seen in Arizona that has led to improvement is including the disability community in these conversations. In the beginning, we were kind of fighting from the outside, but now that we are included, we have been allowed to present and have good, meaningful conversation. We have seen improvements. And as we now roll out the 5 to 11 vaccine, I hope that continues so that population and any other community members who wish to be vaccinated can receive the vaccine in an accessible location. So thank you. And I think we have time for questions, correct, Louis?
Yes, we do. All right. Thank you so much, Blythe and JJ. Really appreciate your fantastic presentation. Okay, all of you, remember this is your good time to submit your questions in the chat window, and we'll get to those in a moment. I wanted to supplement JJ's point about the resources and remind you that this webinar series, in fact, you should go back and look in the archive at ADA presentations. There have in both the emergency management and in the healthcare section, there have been presentations about COVID-19 and the vaccines, setting up sites and other elements that you may find important. So those are really good resources for you as well as the Office of Civil Rights and HHS discussing some of their resources. All right, let's move to some questions. And the one question that I saw at the beginning before I lost everything, I think for Blythe, was a question about hesitancy among people with disabilities to any kind of vaccine, COVID or non-COVID. Was there anything, did you have any data about that?
Yes, thank you. I think that's a great question. And, you know, I mentioned at the end of my presentation, I'm seeing some positive movement in collecting disability status and other data sources. And one of those is exactly working with our immunization partners at CDC. And in fact, you know, the National Immunization Survey is an ongoing survey. It has not collected disability in the past. So we don't have the data right now. However, through these discussions about COVID and getting disability questions on the COVID module, we've actually, you know, forged those relationships and have been successful at getting them to add all 6 HHS questions to their normal national immunization survey. And so they're starting to get those data in. They're being fielded right now. We don't have an adequate sample size for the vaccinations being measured to analyze those data yet, but as soon as we do, we'll be taking a look at them. And so I'll say stay tuned, but I think it's a huge win, at least as far as I'm concerned at CDC, in that we'll be able to now regularly, at least for the foreseeable future, monitor vaccine rates and hesitancies among people with disabilities. So that's the good news.
Great, that's great. Thank you. All right, the next question. The largest number of people with disabilities is among the elderly. Many are multiply disabled, and a majority over 75 are not able to use a smartphone or computer. A significant number have, quote, hung up their keys and may be homebound. We must provide a system of case management services to provide outreach services. So that's really a statement, but there is a question associated with that for me, Blythe, and that is is there any way, or have there been any measures of people who were homebound and who were not able to even get to vaccine sites, and their, any data about them? Because we know that in our region there have been several people who we've had to deal with who did not get the vaccine even when they were able to, because no one actually would go to their house.
Yeah, so similar to having challenges with collecting data for people with disabilities, I think we had the similar struggle with people who are unable to leave their homes. And I think I saw a later question later on about how that's defined, and I suspect it's a state-specific definition, because I don't believe CDC has a strict definition for that. But I would say we don't have very good data on vaccination rates for that group. I know we talked about adding a question, but there was not enough room at the time. But I will say, the 100 million that I mentioned that we gave to ACL to administer through the aging and disability networks was really intended to reach people with disabilities, whether or not they can leave their homes, but also in particular, older populations who were unable to leave their homes. Or I think, as another question I saw come up, unable to access online services at all. And so, I'll say 100 million for some of our federal partners might be a drop in the bucket, but for us, I think that's near our entire budget for a normal year. That was a significant amount of money that we were putting out, and I'm very, very fortunate to have that during the pandemic to go towards these area resources, to go towards the dial line that I mentioned, the call-in number, so that people who are unable to leave their homes can call and find out how they can get in-home vaccination services, and that should be available. And I think, as JJ mentioned, if you don't get the answer you want at first try, keep asking, because the dial line should be able to connect people who call in to the disability rights organizations in their state or whatever it might be, so that they can get the answers they need to get the in-home vaccination or other services that they might need.
Okay, great. The next question: have you seen any data on COVID's impact on autism or sensory issues, or any data on COVID vaccine hesitancy among those with autism or other IDD?
Yes, we have seen, I think the beginning of my slide deck has a little bit of data. It's pretty broad on intellectual disability, but I know our colleagues at Autism Speaks have a paper out, I think it came out this spring, that looks at a private claims insurance database looking at the impact of COVID-19. And similar to what I showed you at the beginning of the presentation, they noted that people with autism and intellectual disability were 9 times more likely to be hospitalized and had longer lengths of stay. And so there are some data on the risk of COVID and outcomes, and I believe they are doing some analyses on hesitancy specifically in that population right now.
All right, I am going to ask my colleague Gabe to read the next questions. I'm still having some technical difficulties.
Could you let me know where you left off at so I can find where your
Yes,
spot was?
at the autism and sensory issues. Next one starts, do you see additional, and I can't see anymore.
Okay, one moment, please. I'm sorry, I'm trying to find where it is on the list here.
You can ask them any question and then look while they're answering.
Okay. There's a question here about information on rural versus urban hesitancy.
There probably is some data. I would suspect there is some data on that from the National Immunization Survey, though I have not looked at it, so can't speak to it. I can certainly, I would say check the data, the COVID data tracker. There might be some data out there on that. I certainly can. I just don't know it offhand.
Okay. Let's see. I am seeing a higher number from homeless population that seems to reflect approximately 70% of the disability population. Is there a specific message for the homeless population?
I don't know, JJ, do you have any thoughts on that?
I mean, generally, I mean, I think with that particular population, I think the counties need to identify, kind of good pop-up locations that could come to that community and make it available, as opposed to assuming that the one size fits all registration process would apply. So in my mind, I would think that a pop-up would be an ideal solution to at least making it available. And I think you all can think about your particular communities where there might be larger populations of homeless, where that pop-up site could be created, and encouraging, again, not everyone may avail themselves of getting the vaccine, but again, putting yourself in the community would be what I would advocate for.
Okay. Next question is, your surveys are by phone. How do you gather data from those who cannot use phones?
I cannot answer that question. I can follow up. I'm not sure how the National Immunization Survey handles that.
Okay. Next question. What work are all of you doing to fix some of the upstream issues? So instead of accommodating at sites that are inherently inaccessible, working to create a vaccine distribution system that is designed to be accessible from the get-go.
So this is JJ. I would say that we at the center, are trying to make partnerships with the state. So what we've learned about, there are groups in our state that work on vaccines as a whole. So it's not just the COVID vaccine. And so now that we've been introduced to them, we're trying to, advocate for what I've just suggested, not just for COVID vaccines, but for the whole vaccination process. So, and we've suggested some of these tips to them, so to make this system better well after the COVID vaccine. So that's our vision, is to make sure that we're not just doing it one time, or we're not just trying to just put out each little fire, but we're also trying to work on the systemic to make sure that vaccines of all kinds are accessible. So that's at least what we're doing in Arizona.
Okay, thank you. This is Lewis. I'm back. So I do want to answer some of the questions that some people have been asking about the slides and the resources from JJ. The slides are available in the archive section of adapresentations.org. They're actually, today, they're in the schedule page of adapresentations.org in the emergency preparedness. As of tomorrow, it will be in the archive section. And all of those resources will be available to you. All right, the next question. I see great strides in disability preparedness and response to bring those at the table that often are marginalized. Do you see those positions continue to be funded as they need seem as the need seems great as the gaps identified during COVID?
So I would say that through the American Rescue Plan and other COVID funding opportunities, we have been very successful at getting those monies to help address some of these issues. You know, in terms of the longevity of those funding streams and sustainability, I think it's hard to say. We are giving lots of thought on how to make what resources we have been successful at getting sustainable, whether that's, you know, providing training services to disability specialists within state health departments and leveraging some of the expansion of the public health workforce that this administration has been very interested in. You know, we'll continue to think about the sustainability issues, but you know, I don't know what's to come in terms of funding in the future.
So if I could jump in, Dr. Ryerson, if you have the ear of anyone, one idea that I have is there's a lot of money coming in right now, and we're a recipient of vaccine equity funding as well. That giving some flexibility, I guess, on that to make these items sustainable. So as I just said, I don't think the COVID vaccine issue has raised a number of issues that we in the disability community probably already knew, that there was inequities, that there were barriers, et cetera. We, prior to vaccine equity and COVID, were dealing with emergency preparedness. And so I think funds that remain or funds that remain unspent should be invested into that, making sure emergency preparedness plans are implemented across the nation so that if various issues arise, not just COVID pandemics, that we are making sure that our disability community is ensured that they have access to the resources they need to get through that particular emergency. So I do think there is going to be some money left unspent. And so if those monies could be invested in these sustainable long-term projects in partnering disability organizations with local governments to make sure that their preparedness plans are updated, address the items that we talked about today, so that when an emergency arises, hopefully not another pandemic, but if there's a flood, if there's a hurricane, that a lot of these measures are in place. So just an idea.
Great, thanks, JJ. There's been a lot of conversation in the chat room about the homebound question, talking about different people, different organizations across the country and different ways in which areas are dealing with that. So that's useful. I'm not going to read all of those. Here's another question for you. There also needs to be people to help direct and guide people with low vision or blindness. Fortunately, I had lots of help with that by volunteers at sites. But I also had people run at my guide dog because they just saw a dog.
So this is JJ. I would say service animal issues always come up, and they've come up here as you've noted. So continued education, you know, for these sites to include. I did not have a slide or a bullet point on service animals, but understanding that the rights of service animals and those that use them have access to all of these vaccine sites. There's no restriction on them. And so again, I think some information put out, and obviously you're familiar with the Department of Justice resources that existed pre-COVID. It still applies, and applies to vaccine sites, regardless if they're Title II or Title III. Service animals have a right to be there with you and anyone else that uses a service animal.
Okay, and as if to cap off all of the issues, we lost the captioner, so we're going to pause here and hope that the captioner can get back in. We don't want to pass along information without the captioner being here. So give us one moment. We'll see if they come back. And also, if you want Blythe's email address, it's there in the chat room, ztq6@cdc.gov. So bear with us for a moment while we wait for the captioner to get back. All right, well, we are not seeing the person jump back in, the captioner jump back in. So instead of taking much time, we're pretty near to the end of the time. So I'm going to close the questions and answers. And we realize that many of you may still have questions for our speakers, and apologize if you did not get the chance to ask your question. Please contact your regional, oh, hold on, she just jumped back in. Okay, our captioner is back. Okay, captioner, can I see your captions? There we go, okay. So sorry. Well, given that, let's take a couple more questions. Are you aware of any programs or grants or otherwise, that can assist individuals or agencies in obtaining communication cards or other assistive devices?
So this is JJ. I posted our Arizona Commission for Deaf and Hard of Hearing's communication card that my understanding is they created it internally. If you visit their website also, that's in Spanish. I'm assuming you could use something like that, so that could address that. Now, in terms of other assistive technology or needs, and not understanding, exactly what someone might need, but, again, maybe that's something that Dr. Ryerson knows if there's money out there for things like that. But again, I would just say from a legal perspective, both the public entity and the public accommodation needs to provide that. I understand your question, is there additional monies out there to buy that? There may be. I'm not aware of that specifically, but just understand that you do have an obligation if you're Title II or Title III public entity or public accommodation to provide the accommodations that we spoke about today. But there could be some resources out there. Again, I don't know every state and territory, but a great place to start is your Department of Health Services, and then your vaccine equity groups that are working. They may have some flexibility in how they use their funds, but I can't speak for them. But those would be a couple contacts I would make with that question.
Yeah, I think those are great suggestions. I'm not aware of anything specific, but JJ had some good thoughts.
Okay, many of the questions that are remaining are ADA related questions about whether you can wear a mask and oxygen devices. These questions can be brought up with your regional ADA center at 1-800-949-4232. You may also be able to contact JJ. He may be willing to do it if you're outside of his region, his area. I'm not sure, but he'll be able to answer that. But the ADA centers offer you free advice on the Americans with Disabilities Act. So we appreciate you being here. We are sorry if you didn't get a chance to ask your question, but again, if your question is an ADA question, you can contact your regional ADA center. You will receive an email with a link to the online session evaluation. Please complete the evaluation for today's program, as we value your input and we want to demonstrate the importance of this series to our funder. We want to thank our speakers today for sharing their time and knowledge with us. It was a great presentation, very valuable. A reminder that today's session was recorded and it will be available for viewing next week at adapresentations.org in the archive section in emergency management. And watch your email 2 weeks ahead for the announcement of the opening of registration for our next session. Thank you again for attending today's session. Thank you again to Blythe and JJ for being great presenters today, and have a good rest of your day, everyone. Bye-bye.